next generation sequencing has been more and more implemented into these patients for one, assessment of their long-term outcome, disease behavior in terms of disease progression. So we knew for quite years now that there are certain mutations that predict better disease behavior, so-called high-risk mutations. For example, ASXL1, EZH2, IDH mutation, certain splicings. So we were testing them randomly to just basically put them in a field and to see how they're gonna go, right? Now we know that they do actually prognosticate for long-term behavior or for the disease progressing or behaving unexpectedly. So I think they should become more a standard of care for a long-term care, especially now in the era of novel therapies, where hopefully and maybe we are going to move the field goals for controlling the thrombotic risks, controlling the symptoms, to controlling the disease itself in terms of its background, such as risk of progression, risk of going into myelofibrosis or death or acute leukemias. So those could help us to better dissect the disease pathology and behavior, and maybe allow us to act proactively. So really identify the worst patients and then taking them into more adverse therapies up front and prevent the disease progression. So I do think this has a big role in the future. And I know there always is cost versus benefit, but if we at least learn which patients actually need it, are more risky, they would really play the game.